Well, kidney involvement is a major complication in the course of diabetes, as it influences in the natural course of the disease, and also it increases morbidity and mortality, and also increases the cardiovascular risk. Although we say that diabetic kidney disease is generally considered as a complication of microangiopathy, and cardiovascular disease is a complication of macroangiopathy, there are also common pathways which are implicated in both diseases. Apart from that, moreover, when chronic kidney disease develops because of diabetes, this is a particular one more reason for the cardiovascular as a cardiovascular risk and the risk of mortality. So it means that when we talk about biomarkers in cardiovascular disease in patients with chronic kidney disease due to diabetes, we have to see that in two ways, in both ways. We have to see that in a way of common biomarkers affect both diseases, and also we have to discuss about chronic kidney disease, the way it affects the cardiovascular disease. So there are very well described and very extensive research and studied traditional factors, newer factors, and many novel factors which can act as biomarkers in a cardiovascular disease. Some of them are lipoxygenases, matrix metalloproteinases, FGF, CLOTH. Now we are going to talk about some novel biomarkers, and especially we're going to concentrate in biomarkers which are both implicated in chronic kidney disease, diabetic nephropathy, and cardiovascular disease. If we see the factors which are implicated in the development of diabetic kidney disease, we can see these genetic, hemodynamic, metabolic factors which are very well described, but we also have immunological factors, chronic inflammation, and lately described cellular senescence in the diabetic kidney disease. The most interesting thing is that all of these factors are collecting to each other, so we can say that genetic factors will influence metabolic factors and hemodynamic factors, and metabolic factors, which are also always due to hyperglycemia, will increase advanced glycation end products, activate protein kinase C, activate hexosamine and polyol, and from the other hand, we've got the hemodynamic factors with RAS and endothelin dysfunction, and they will all act through immune mechanisms, chronic inflammation, which will lead to cellular senescence and renal hyperglycemic memory. What are the AGEs? Advanced glycation end products. These are products of non-enzymatic glycosylation of proteins, lipids, and nucleic acids. They have a very significant role in the development of diabetic kidney disease, but they also have a very significant and crucial role in the development of cardiovascular disease through many ways, probably because of modification of the intracellular proteins, plasma proteins, extracellular matrix, endothelial dysfunction, and also by controlling the response of cell surface receptors. There are many studies which showed that higher levels of AGEs in type 1 diabetes will act as biomarkers for fatal and non-fatal cardiovascular disease and all-cause mortality. And very interestingly, there are some studies which showed that increased plasma levels of AGEs in patients with end-stage renal disease, even in patients with end-stage renal disease due not to diabetic, non-diabetic patients with chronic kidney disease, will have a positive correlation with endothelial dysfunction and low-grade inflammation. Another topic is that AGEs can be accumulate in tissues, and they accumulate usually in tissues with slow turnover of protein, such as collagen. So when we do skin biopsy, we can see these AGEs either with confocal microscopy, as we see here, or with immunohistochemistry. Well, that does not mean actually that we need to have a skin biopsy to see and measure the ages in the skin, because lately we've got this AGE reader. This is an implement that can measure ages accumulation in the skin. Its function is based on the fluorescent properties of several ages, and it calculates the skin autofluorescence as the ratio of emission to reflected excitation light. It is interesting that positive correlation of the intensity of SAF is because there is a positive correlation between SAF and the degree of immunohistochemistry in patients with ages accumulation. And there are also lots of studies which show that ages in skin, accumulation of ages in the skin, as measured by the SAF biomarker, this intensity can be used as a biomarker for early development of subclinical cardiovascular disease, and also as a biomarker for cardiovascular outcomes. As we can see here, cardiovascular mortality, new cardiovascular events, or major cardiovascular events in a follow-up for up to 5 years. So ages can be used as a biomarker, and there are several ways that we can measure ages in patients with diabetes and in patients with chronic kidney disease. Ages are representative of metabolic disorders, and here we've got the disorders in the immune system in patients with diabetic nephropathy. We know that there is a disorder of immune mechanisms, and that influences either both innate and adaptive immunity. And we can see here that the innate immunity, which is disturbed in patients with diabetic nephropathy, affects membrane receptors, cytoplasmic receptors, signaling pathways, and complement pathway. If we see these membrane extracellular receptors, DAMPs, ICAM1, VCAM1, PRRs, and cytoplasmic receptors, we have to concentrate on these AGE receptors, which are usually found in endothelial cells, and they are increased in patients with diabetic nephropathy. And when they connect with AGEs, they result in the activation of protein kinase, production of NF-kappa beta, and then upregulation all these molecules here, which are found to have as a result in increased vascular permeability and increase in atheromatosis and cardiovascular disease. What about the signaling pathways? Signaling pathways which are activated in patients with diabetes are the P38-MAPK, JAK-STAT pathway, and TNF-alpha signaling pathway. The first one, P38-MAPK, is activated due to hyperglycemia. The first molecule which is increased is the apoptosis signal regulating kinase 1, ASK1, which will result in the activation of P38-MAPK, and this is going to increase the inflammation, fibrosis, and apoptosis. When we try to abrogate ASK1 or P38-MAPK by giving an ASK1 inhibitor, we will see that we have a reduction in inflammation, reduction in fibrosis, and a reduction in macrophage accumulation. In the same way, when we try to abrogate JAK-STAT pathway, and this has been done only in vivo studies, not in vivo, in vivo studies, only in diabetic rats, we will see that we have a beneficial effect in histology and also a reduction in proteinuria. On the other hand, if we administer JAK2 in diabetic rats, we will have a deterioration of histology and a declining renal function. And we've got the TNF-alpha signaling pathway, And there are lots of studies, some of them are from our own department, where we found that either locally or systemically, TNF-alpha signaling pathways is upregulated in patients with diabetes and with diabetic nephropathy. And it was very interesting that urinary TNF-alpha, which represents the intrarenal increase of TNF-alpha, is upregulated, is increased in patients with diabetic nephropathy, even with just low levels of proteinuria. So what does it mean? Do we have signaling pathways activation in patients with cardiovascular disease? And does it have any importance in, as a biomarker in the cardiovascular disease? There are not a lot of studies in patients with cardiovascular disease and signaling pathways. Most of them are experimental studies, and I have to draw your attention here on the effect of apelin, a drug which can inhibit apoptosis, inhibit P38 MAPK pathway, and reduce INOS, and it seems to have a cardioprotective effect in diabetic rats. So the signaling pathway may have some importance in cardiovascular disease in patients with chronic kidney disease. And we come to the complement pathway. The complement pathway, we all know that there are three ways to activate complement: the classical pathway, alternative pathway, and the lectin pathway. And it seems that in patients with diabetic nephropathy, we have activation of the classical pathway. We can see that because when we do a renal biopsy in a patient with diabetic nephropathy, we will have about 50 to 60% chance to have a significant glomerular C3 deposits. That means that the classical pathway is activated, and we also have deposits of MBL. That means that lectin pathway is also activated in these patients. What does it mean? It means that when we have classical pathway and MBL activation, that may have an impact in the increase of cardiovascular disease, because CO1Q levels has been found by many studies to be an independent factor as a predictor of mortality in patients with cardiovascular disease. And apart from that, it has been described as having a unique effect on early atherosclerosis, and this effect is independent of complement activation, probably by regulation of AGEs or intervention in apoptosis. Also, the classical pathway by C1Q can contribute to the progression of atherosclerotic disease, and as we said, it can act as an independent factor in cardiovascular mortality. So C1Q can be used as a biomarker for cardiovascular disease in patients with chronic kidney disease. And we come to the adaptive immunity. Adaptive immunity is based on B lymphocyte and T lymphocyte activation. T lymphocytes are activated when the antigen is presenting on their T cell receptor by the professional antigen presenting cells, which are the dendritic cells. Apart from that, we need to have another connection between B7-1 and CD28. This CD28 receptor is a very interesting receptor, and we have seen that there is a very interesting reduction of the CD28 receptor in patients with diabetes and in patients with chronic kidney disease. These are some data from our studies during the last years. We found that CD4, CD28 null cells, and CD8, CD28 null cells are increased in patients with chronic kidney disease, and even more in patients with chronic kidney disease due to diabetes. And this will have an impact in increasing the atheromatosis, cardiovascular disease, and they correlate with macroangiopathy. These are our data here. which show that in patients with chronic kidney disease due to diabetes and due to non-diabetes causes, we found that there was a reduction in CD28 null cells, as we can see here, either CD4 or CD8. And here we can see what is happening after these patients start on hemodialysis. This is the panel of the patients which were non-diabetics. When they started on hemodialysis, we can see that CD4, CD28 null cells were reduced. And here we can see that CD8, CD28 null cells were also reduced and Tregs were increased. What happened to the diabetic patients? We can see here that patients who started on hemodialysis had an increase on CD28 null cells, and that affected both CD4, CD28 null cells and CD8, CD28 null cells. I mean that patients with diabetes, when they start on hemodialysis, they have even further deterioration of CD28 molecule on the T lymphocytes. And that was found to correlate with IMT and with cardiovascular events. So it means that CD28 receptor can also probably be used as a biomarker in these patients for the development of cardiovascular risk or cardiovascular mortality. And this is another very interesting and very recent study we've got. We found that uremic toxins, which are increased in patients on hemodialysis, have a close correlation with all these T lymphocyte phenotypes, and probably they are implicated also in the cardiovascular risk through the endothelial dysfunction. We can see here that intoxyl sulfate will induce endothelial dysfunction, but here we've got the picrecyl, another uremic toxic, which synergistically with AGs will induce endothelial dysfunction in patients with end-stage renal disease. And as a conclusion, we've got the traditional biomarkers and we've got the novel biomarkers, which are describing during the last few years. They are based on common pathogenic mechanisms for cardiovascular disease and diabetic kidney disease. We have to remember ages, signaling pathways, complement components, and also CD28 null cells, which is a phenotypic subpopulation of T lymphocytes. And the consequences of chronic kidney disease due to the increase of uremic toxics and ages will also have an impact in the cardiovascular disease. Thank you for your attention.